Imagine going in for a routine pelvic MRI, only to have the radiologist pull up the scan and point to this gaping, pitch black void just sitting deep inside your muscle tissue.
Oh, yeah, that is a terrifying moment for a patient.
Right. Or picture a scenario where you develop this really painful antibiotic-resistant bladder stone. And when the surgeons finally go in to remove it, they find that the core of that stone is a single drop of water-based gel that was, like, injected into your body a full decade ago.
It honestly sounds like medical science fiction,
Yeah.
but it is a very real, incredibly hidden frontier of clinical practice. I mean, we were talking about microscopic landscapes here, where permanent invisible implants are placed inside the most sensitive tissues of the human body.
Exactly. So, welcome to this deep dive. Today, we are exploring the fascinating and honestly high-stakes world of intimate fillers.
Yeah, and when most of you hear the phrase cosmetic filler, your mind probably immediately jumps to plumping up lips or, smoothing out wrinkles on a face.
Yeah, Botox, lip injections, that sort of thing. But we are looking at something entirely different today. We are unpacking the highly specialized medical use of gels, beads, and serums that are injected deep into the female anatomy.
Right.
And they're used to solve complex mechanical leaks or fundamentally alter sexual function or even restore external volume.
And doing this, it requires a level of anatomical respect that goes far, far beyond standard aesthetics. I mean, we are dealing with functional biological valves and highly vascular sensory hubs.
So the stakes are high.
Very high.
Yeah.
The margin between a procedure that changes a patient's life for the better and a complication that takes, like, 10 years to materialize is quite literally measured in single millimeters.
Wow. So by the end of this deep dive, you are going to understand the fluid dynamics of the human body, how a single drop of hydrogel can basically trick your immune system, and why a successful medical outcome hinges entirely on a surgeon finding a microscopic layer of tissue while staring at a camera screen.
It's incredible stuff.
It really is. But to wrap our heads around this, we have to start with the foundational problem these internal fillers were originally designed to fix, right? Which is stress urinary incontinence, or
Yes.
SUI.
Right, SUI.
But we aren't just talking about a weak bladder here, are we? I mean, this is an actual mechanical failure.
Yeah, that distinction is crucial. We are looking specifically at SUI that's caused by intrinsic sphincter deficiency.
Mhm.
So this is not an overactive bladder muscle spasming.
Okay.
You have a sphincter at the bladder neck, right? And its sole biological function is to act as a tight waterproof valve. It stays closed to keep fluid in. But due to, aging, scarring, childbirth, or previous pelvic surgeries, that physical valve loses its structural integrity. It becomes chronically weakened.
Meaning any sudden increase in internal abdominal pressure, whether you are like coughing, laughing, deadlifting at the gym, or just sneezing it, forces that weakened valve open, resulting in a leak.
Exactly. The pipe itself is compromised.
So how do you fix a broken pipe?
Well, for a very long time, the gold standard was major surgery. Surgeons would go in and insert a synthetic mid-urethral sling, literally physically lifting and supporting the tube.
But that's a major operation.
Right, and surgery carries significant risks, it requires recovery time, and it simply isn't an option for every patient. So that clinical gap is what drove the development of urethral bulking agents as a minimally invasive alternative.
Okay, so instead of cutting and lifting the tissue, doctors inject a space-filling substance directly into the walls surrounding the urethra. And medically, there are some wild materials used for this, right?
Oh, absolutely.
Like one of them is Bulkamid, which is a hydrogel made of 97.5% water and just 2.5% cross-linked polyacrylamide.
Yeah, Bulkamid is very common.
And then there's microplastique, which is basically a soft, synthetic silicone elastomer.
And the mechanism at play here is purely structural fluid dynamics. By injecting this dense bulk into the periurethral tissues, you artificially increase the tissue volume surrounding the biological tube.
You're thickening the walls.
Exactly. This narrows the width of the urethra, drastically increasing the resistance to fluid trying to escape. The goal is to bulk the walls up just enough so the inner lining of the tube, the mucosa, can properly touch and seal together. The medical term for that tight seal is coaptation.
Okay, let's visualize this. It's essentially like putting thick leather stripping around a drafty, warped door frame.
That's a perfect analogy.
Right, because the door itself might be structurally compromised and the hinges might be loose. But if you adhere a bulky strip of foam around the edges, you force a tight mechanical seal and keep the draft out.
Exactly, you're filling the gap.
But wait, if we are just weather stripping a biological tube with a water-based gel, like that Bulkamid stuff, The body's immune system is constantly trying to break down foreign material. How does a hydrogel that is like 97.5% water survive in the urethra without just dissolving immediately?
Well, that comes down to the genius of the chemical engineering. That 2.5% polyacrylamide creates this basically indestructible three-dimensional microscopic mesh.
Oh,
Yeah, the human body just does not possess the enzymes required to break those specific chemical bonds. So that mesh acts like an unbreakable cage, permanently trapping the water inside it.
okay, but even with an indestructible cage, this is fundamentally a fluid dynamics patch, not a permanent cure for the underlying muscle weakness, right?
Right. It's a structural fix, not a muscular one.
Because the clinical data shows this weather stripping approach is usually just a temporary fix. The success rates for significant relief hover around, 60 to 70%. That means nearly a third of patients won't even get the result they need from the first round.
Right. And for the patients who do experience a successful seal, they very often face a diminishing return over time.
So it fades.
Yeah, over a period of about 6 to 24 months, the increased urethral resistance starts to fade. The tissue slowly remodels around the implant, the surrounding anatomy shifts a bit, and the structural support weakens.
So what happens then?
The clinical reality is that patients very often require repeat top-off injections to maintain that essential coaptation.
Okay, so you are basically committing to maintenance. Which brings us to the actual physical challenge of putting that gel into the body. Because we are weather stripping a tiny, delicate biological tube, the exact placement of this material is everything.
Oh, it's make or break.
If the doctor misses the target layer by a single millimeter, the entire procedure fails.
It really does. It is an incredibly demanding technical procedure. The patient is typically under local anesthesia, and the surgeon inserts a cystoscope, which is a very thin tube equipped with a tiny high-definition camera directly into the urethra.
So they are watching this live.
Yes, they are navigating this anatomy from the inside out, watching the internal walls on a monitor.
And from the source material, they use a very deliberate tunneling technique, right? The surgeon advances a thin needle into the urethral wall at a steep 30 to 45-degree angle for about half a centimeter.
Right, to pierce the surface.
Then they level the needle out to 0 degrees so it runs perfectly parallel to the tissue wall, and they advance it another half centimeter. So they are actively carving out a microscopic tunnel inside a specific tissue layer called the submucosa.
And that layer, the submucosa, is the absolute only correct destination for this filler.
Why is that?
Geographically, you have to think of the urethra as a layered tube. The innermost empty space is the lumen, where the urine flows. The surface lining right around that is the mucosa. Just beneath that is the submucosa. And beneath that is the thick, structural, periurethral smooth muscle.
Okay, so it's lumen, mucosa, submucosa muscle.
Exactly. The surgeon must deposit the filler perfectly into that middle submucosal plane.
But they are inside the tissue wall with this tiny needle. So how on earth do they know they are in the right spot? What are the immediate real-time visual or tactile signs that they've messed up and gone, say, too deep into that smooth muscle?
It relies entirely on immediate visual and tactile feedback through that camera monitor. When the surgeon begins to pull the lever on the administration device to release the filler, they are looking for a highly specific visual cue.
Okay, what is it?
If the needle is perfectly seated in the submucosal plane, a bleb will instantly appear on the screen.
A bleb. I love that term.
Yeah, it's very descriptive.
It's basically a small, visible cushion or blister of tissue that aggressively bulges outward directly toward the midline of the urethra, right?
Exactly.
So you can physically watch the wall plump up on the monitor and close the empty gap in the tube.
Yes, that bulging bleb is the definitive visual confirmation of success. Now, if the needle is deposited too deeply, meaning it bypassed the submucosa entirely and punched into the smooth muscle, the visual feedback changes drastically.
So what do you see if you're too deep?
Well, the immediate sign of a deep injection is a complete lack of that midline bulge. No bleb forms.
Oh, wow.
Yeah, the tissue might start to swell diffusely, just kind of puffing up everywhere, but the cushion completely fails to reach the midline, no matter how much filler the surgeon pumps through the needle.
Because the filler is just getting lost in the vast expanse of that deep muscle tissue rather than pushing the surface lining inward to create the seal?
Exactly. It's just diffusing into the muscle.
So if you are staring at that screen and you don't see that precise bubble form, you have to stop immediately. You can't just forcefully pump more volume in, hoping it will eventually bridge the gap, right?
No, absolutely not. Pumping more volume is how you create severe complications.
Like what?
Well, If you force too much material into the wrong tissue plane, you risk acute urinary retention. The massive localized pressure from all that misplaced gel clamps the entire biological tube completely shut.
Oh.
Yeah, the patient literally cannot urinate at all and will require a catheter to mechanically drain their bladder until the internal swelling subsides. It's incredibly painful and dangerous.
So, tactically, what is the fix in that exact moment during the surgery? If the surgeon sees the tissue isn't bulging toward the midline, what do they do?
They have to slowly and carefully retract the needle. They pull it back slightly to locate that more superficial submucosal layer.
Just pulling it out slightly.
Right. And while pulling back, they continuously inject tiny micro amounts of the gel, feeling for that specific tactile pocket of resistance. They're waiting for that distinct cushion, the bleb, to finally pop up on the screen.
That sounds so tedious.
It demands immense patience. The clinical guidelines actually stress waiting several seconds between each micro pull of the administration lever.
Wait, think about the fluid dynamics there for a second. If the submucosa is a tight, closed tissue plane and you are pumping this viscous gel into it, you are building up immense localized pressure.
Exactly.
So if the doctor gets impatient and pulls that needle completely out a second too early, doesn't all that gel just shoot right back out of the puncture hole?
Yes, it takes the path of least resistance. If you don't allow the pressure in that microscopic tunnel to equalize before withdrawing the needle, the material extrudes immediately.
And you completely lose your weather stripping seal.
Exactly. You're back to square one.
It is stunning how much rides on a millimeter of depth, a visual bubble, and just a few seconds of pressure equalization.
A very delicate art.
But here's where this gets really interesting to me. We've been talking about using this exact procedure to block flow and fix leaks. But by shifting the target just slightly within the same anatomical neighborhood, the medical community has co-opted this exact same concept for female sexual enhancement.
Yeah, the transition from functional continence to sensory pleasure is fascinating. Clinically, this is known as G-spot amplification, or GSA.
Right.
And the anatomical rationale here centers on the clitorethrovaginal complex. Data suggests that women who consistently experience vaginal orgasms possess a measurably thicker urethrovaginal space. The tissue architecture is naturally just more robust.
So the clinical logic being, if nature didn't provide a thick urethrovaginal space, medical intervention can build one.
Exactly.
And there are completely different ways to approach this. There is a transvaginal approach, injecting materials through the vaginal wall. But there is also a transurethral approach that uses the exact same cystoscope and tunneling tools we just discussed for incontinence.
Right, same tools, but the destination changes. Instead of injecting into the submucosa to block urine flow, the surgeon aims deeper.
Okay, where to?
They might inject a permanent filler, like that macroplastic silicone elastomer we talked about, directly under the urethral musculature.
Because they aren't trying to close the tube this time. They're creating a firm structural bulk that actively pushes the G-spot structures downward toward the vaginal lumen.
Yes, exactly.
Think about the geography of that. They're essentially putting a firm cushion behind these highly sensitive sensory structures, pushing them closer to the surface right where the physical friction actually occurs during intercourse.
You are fundamentally altering the physical topography to make sensory stimulation easier. And it's important to note that the materials used dictate how the body responds.
Right, because there are different options.
Yeah. If we look at pilot studies comparing different transvaginal injectables, specifically cross-linked hyaluronic acid versus platelet-rich plasma, or PRP, the mechanisms of action are totally distinct.
And the results were really different too. Studies tracking the female sexual function index over a 3-month period showed that cross-linked hyaluronic acid yielded a massive 68.1% improvement in scores.
That's a huge jump.
But the PRP group saw a 45.7% improvement. That's a significant gap between the two.
Well, the gap is entirely due to how the materials behave biologically. Hyaluronic acid provides an immediate mechanical volumetric lift. It instantly plumps the physical space, providing that rigid structural scaffolding for immediate stimulation.
It's just physical bulk.
Right. But PRP functions completely differently. With PRP, you are spinning down the patient's own blood to extract growth factors. So injecting PRP triggers neurovascular modulation.
So it's not just taking up space. It is actively stimulating the body to build new blood vessels and regenerate nerve endings in that specific area.
Exactly.
And that biological repair process takes significant time, which perfectly explains why the immediate impact on pure physical volume and sexual function scores is lower compared to the instant lift of a gel.
Right. It highlights the incredible duality of this anatomical region. I mean, it acts as a mechanical load-bearing valve holding back liquid pressure, but it is simultaneously this hypersensitive neurovascular hub.
You alter the structural scaffolding and you intimately change the sensory feedback.
Exactly.
Now, we've been talking about using these fillers as internal structural scaffolding, whether to stop a leak or enhance sensation, but the massive booming market for intimate aesthetics has completely co-opted this medical tool for something else entirely: external cosmetics.
Oh, yeah. And the transition to external aesthetics is really where clinical definitions get dangerously blurry for patients.
It gets confusing.
Very. We see a massive rise in procedures like the labiopuff. This specifically targets the labia majora, the outer external folds of the vulva, aiming to restore external volume lost to aging or significant weight loss, almost exclusively using hyaluronic acid fillers.
But clinics routinely market this procedure under the vague umbrella term of vaginal filler.
Which is scientifically inaccurate and creates a very dangerous clinical disconnect. The labial puff targets external aesthetic volume, period.
It's just outside.
Right. It has absolutely zero impact on the internal vaginal canal. It will not treat internal conditions like genitourinary syndrome of menopause, structural prolapse, or internal dryness and pain.
Okay, let's ground this in a metaphor for a second. Treating severe internal pelvic pain with an external labial puff is essentially like repainting the outside of a house when there's a massive termite infestation destroying the foundation.
That is exactly what it's like.
You are masking a deep structural or biological crisis with a superficial cosmetic fix. If you go into a clinic expecting an external filler to cure internal pain, your expectations are dangerously misaligned with the actual anatomy.
And this is exactly why rigorous clinical assessment is non-negotiable. If a patient presents with pain, burning, or bleeding, a physician must diagnose the root cause, be it a severe infection, a hormonal deficiency, or precancerous skin changes. You simply cannot ethically inject a cosmetic volume filler over an undiagnosed medical symptom.
And even though it is an external cosmetic procedure, the biological risks are still really severe. The labia majora is a highly vascular zone, meaning the tissue is densely packed with a complex network of blood vessels.
Yeah, and injecting dense gels into vascular zones requires absolute precision. Practitioners must perform gentle aspiration before ever releasing the filler.
They pull back on the syringe first.
Right. They pull back slightly on the syringe plunger. If blood flashes into the syringe, it is the immediate glaring warning that the needle has punctured an artery or vein.
Because if you inject a thick, viscous hyaluronic acid gel directly into a blood vessel, it creates an embolism, right?
A massive embolism.
The gel basically acts like a concrete plug in the circulatory system. It completely blocks the blood flow, and the surrounding tissue literally starves of oxygen and dies, a process called tissue necrosis.
It's awful.
Yeah.
The vascular risks are immediate. But there's a much longer, silent timeline we have to consider too. Whether you are injecting a hydrogel internally to weather strip the urethra or hyaluronic acid externally for aesthetics, these materials are engineered to stay in the body for a very long time.
Right, they don't just disappear.
Exactly. So what happens to these synthetic gels and beads 5 or even 10 years down the line?
Well, they become ghosts in the machine. They haunt future medical imaging. Let's say a patient had periurethral collagen injected for incontinence years ago. If she later goes in for an MRI of her pelvis, that ancient pocket of collagen can look exactly like a highly dangerous solid tumor, specifically a urethral leiomyoma.
Yeah.
Imagine the absolute terror of getting that preliminary MRI result.
It happens. And differentiating between an old cosmetic filler and a new aggressive tumor requires some advanced radiological sleuthing. Radiologists have to rely on an intravenous contrast dye called gadolinium.
How does that help?
Well, a true growing tumor has an active blood supply, so it absorbs the gadolinium and lights up brilliantly on the scan. But a decade-old pocket of filler has no blood vessels, so it remains dark.
And it isn't just collagen either. Remember Durasphere, the bulking agent made of carbon-coated zirconium oxide beads.
Oh, yeah.
On a T2-weighted MRI scan, those microscopic carbon beads appear as extremely dark, high-point tense voids. They literally look like strange, gaping black holes peppered throughout the muscular wall of the urethra.
It's bizarre to see on a scan.
But confusing an MRI radiologist is merely a diagnostic headache. The actual physical complications of long-term fillers are astonishing.
They really are. There's a documented case in the European Medical Journal that perfectly illustrates the long-term biological consequences of a single millimeter error.
The bladder stone story.
Yes. A patient presented with recurrent agonizing cystitis, a bladder infection caused by a highly antibiotic-resistant strain of E. coli.
And when the surgical team went in to investigate, they found a massive bladder stone. But the core of this calcium and struvite stone wasn't natural biological matter. The rock was completely adhered to and had grown around a piece of Bulkamid filler.
Yeah.
And that filler had been injected for incontinence 10 full years prior. 10 years.
It's wild. But to understand how a drop of water-based gel turns into a calcified rock over a decade, we have to look at the pathology.
Yeah.
The Bulkamid filler had extruded into the urinary tract. It slowly pushed its way out of the urethral tissue and became exposed to the open flow of urine.
Why did it extrude in the first place?
Well, this extrusion almost certainly happened because, 10 years earlier, the surgeon failed to inject the gel deeply enough into that precise submucosal plane.
The initial placement was too shallow, so over years the body slowly pushes it out.
Exactly. And once that gel is exposed in the bladder neck, the biological cascade begins. Because the synthetic gel has no blood supply of its own, the body's immune cells, the white blood cells and macrophages, they cannot reach it.
So it becomes this untouchable fortress.
Right. And E. coli bacteria are incredibly opportunistic. They latch onto this exposed immune-free gel and form a dense biofilm. That biofilm protects the bacteria and allows them to thrive. And then the bacteria release an enzyme called urease, which breaks down the urea in the urine into ammonia.
Which causes a massive localized spike in the pH level. The urine becomes highly alkaline.
Yes.
And when the pH spikes, the calcium naturally present in the fluid crashes out of solution and crystallizes. It's a process called uriolysis, right?
That's the one.
The bacteria literally build a calcified, rock-hard shell right on top of the gel.
It is a microscopic, cascading failure of fluid dynamics, immune evasion, and chemistry that takes an entire decade to fully materialize.
It's exactly like a shipwreck sinking to the bottom of the ocean. You leave a foreign synthetic structure in a fluid environment long enough, and eventually, a complex coral reef is going to grow all over it. Except in this human ecosystem, it's a painful, antibiotic-resistant bladder stone growing on an extruded hydrogel.
That is a brilliant way to put it. And this specific pathology synthesizes everything we've analyzed today about precision. I mean, a procedure that takes 15 minutes in a clinical outpatient setting carries lifelong biological implications. A needle that misses the submucosal plane by a single millimeter today, or a surgeon who impatiently pushes the plunger without seeing that distinct midline bleb form on the monitor, is setting off a 10-year biological chain reaction.
It is the ultimate clinical butterfly effect, localized entirely within the female pelvic floor.
Okay.
The duality of these intricate fillers is just staggering. We are wielding tiny syringes of cross-linked gels to weather strip the urethra against sudden pressure leaks. We are using structural bulking to fundamentally push the G-spot downward and alter sexual sensory feedback. And we are utilizing external labial puffs to reshape aesthetic topography.
Yeah, it's a huge spectrum.
They carry immense functional, neurological, and psychological impacts. But the margin between an absolute clinical triumph and a decade-long calcified complication is razor thin.
It demands an uncompromising respect for the layered anatomy, a deep understanding of fluid dynamics, and absolute transparency with the patient about exactly what synthetic material is being integrated into their tissue and precisely where it is going.
Which leaves you, the listener, with a final, slightly provocative idea to ponder. We know that the human body is not static, right? Hormones fluctuate, tissue elasticity degrades, and a pelvic floor at age 40 behaves vastly differently under physical stress than a pelvic floor at age 70.
Right, we are always changing.
So if the anatomical environment is constantly evolving, what if the future of these intimate medical interventions isn't a static, unchanging hydrogel or a permanent silicone bead?
Oh, you're talking about moving beyond passive scaffolding.
Exactly. What if the next incredible medical frontier is a smart biomaterial? An intelligent implant that can actively adapt, structurally expand, or even safely dissolve on command in response to the aging body's changing mechanical needs, rather than just sitting in the tissue for a decade, waiting to become a ghostly void on an MRI or a structural reef for a bladder stone.
An implant that biologically evolves in tandem with the patient, that would completely rewrite the clinical paradigm. It's a fascinating thought.
Something to think about the next time you hear the word filler. Thank you for joining us on this deep dive into the source material. We'll see you next time.